Thanks. It's really a pleasure to be here, and I'm really quite honored. Hi, Elspeth. How are you? Um, uh, when I was putting the talk together, I recognized that there's different members of the audience here, and I try to meet the various members' needs. And I know some people, residents here, are looking for sort of maybe just a comprehensive overview. Others are experts in this area, and maybe just looking for a few grains of nuggets. Some come to be challenged. Others are probably looking for an early exit opportunity. Um, I think one thing we probably all agree on would like to see is Andrew McNeely put on the spot. And strangely, that's uniformly, I think the opinion, even with Andrew, somewhat masochistically. So that's not an easy thing to do, but I'm going to try to accomplish all of this. You may be wondering, some of you, where Iowa is, and so this is the MapQuest, and it's really not in the middle of nowhere, but you do have to drive through the middle of nowhere to get to Iowa, and it's several thousand miles, as you can see, and I decided I'd take the plane. Julie was one of my patients and had a neurogenic bladder. And I took over her care in 1999. As you can see, she passed away in 2013. And I've had several patients like Julie with a neurogenic bladder who have passed away way too early. She died of pulmonary complications. But it did make me start really thinking about what are we doing for these patients? Are we doing the best we can? And so, although it may be a strange thing to do, I'd dedicate this talk to her. She really was an amazing young woman with quite a spirit. So objectives today, again, I've covered some of what we want to discuss. I do want to focus on what's not known as well, and keeping in mind patients like Julie. For the residents, some of this should be familiar. Spina bifida is the most common cause of neurogenic bladder, and by far and away it's myelomeningocele. And during the talk, we'll talk about a few of the differences in myelomeningocele and lipomyelomeningocele tethered cord, and how they're a little bit different as far as their presentation and outcomes. Let's talk about myelodysplasia as a success story for a minute. There have been significantly increased rates of infant survival over the last 60 years, as you can see. In the mid-50s, very few lived past 2 years of age. But with the VP shunt, a lot more of them started living, as you can see. And now you can expect most of them to live into adulthood. And this presents urologists with new challenges, because a lot of these patients will become your patients, the adult urologist patients. And so you've got to understand some of the things you should be following and things you should be trying to prevent. Another part of the success story is decreasing rates of renal failure, as well as decreasing rates of augmentation cystoplasty. And you can see the numbers there that have decreased significantly. Part of this was the development of intermittent catheterization by Lapides in '72. And if you go back and look at Lapides' article, one of his underlying hypotheses for why intermittent catheterization would work, and it's sort of been forgotten, is he thought it would improve blood and lymphatic flow to the bladder. When it was overly distended and stretched, he thought the lymphatic flow wasn't very good. That's why they were getting infections. That's kind of been forgotten. We've thought more about it more as just sort of the mechanical washing out, basically, emptying. And that's why it helps with prevention of infection and things like that. But I do wonder if he was right on some of this, and if there's more to intermittent catheterization than we think about. Ed McGuire in Michigan recognized when he retrospectively looked at patients with spinal cord issues that if the leak pressure was above 40 centimeters of water, they had a much higher incidence of renal damage than those that leaked at a lower pressure. Stu Bauer, as I'll talk about in a minute, helped us recognize that if you've got a bladder working against a sphincter and there's a lack of coordination, those patients are at high risk for damaging your kidneys. So things you would expect and things that sort of become urologic common sense to us. There's been prevention and a decline of MMC. Some of that's from the recognition that folate can help. Other is from abortion or termination. First question. Who's the legendary University of Iowa wrestling coach?
Martin Glee.
Anyone? No one knows. Okay. No, it's Dan Gable. And so when you look at Andrew McNeely, he looks sort of like a wrestler. And you know, it's hard to put him on the spot. He looks like he's had his Wheaties this morning and gone for a brisk 20-mile run. Probably picked a fight with some Navy SEALs on the beach or something like that. So I couldn't get Dan Gable to come here this morning, but I'm going to recruit him to help put you on the spot a little bit. So why is he a legendary? In '72, he won the gold medal in wrestling in the Olympics. How many points did he give up in the Olympics? A, B, C, D, E. Larry knows how to take tests. Absolutely. E's right. He didn't surrender a single point in the Olympics. Can you imagine being so good that you can not only go to the Olympics and win, but you're wrestling the best people in the rest of the world, and they don't even score a point on you? That's how good he was. He's named one of the top 100 Olympians of all time. This was his record in high school. In college, he lost one match. I'm sure that irritates the heck out of him. His coaching record, 15 national titles. This was his record as a coach over the years, a 94.4% win rate. Coached 45 national champions. This is a man who has been very successful. The coach that followed him, Tom Brands, won a national championship and was very happy about it. And he tells the story that right after that match, Dan Gable came up to him and said, "That was good, but you can do better." That's how intense he is. So why do I tell you this? Well, there's a question for Andrew. We got to imagine that Dan Gable is here. Would you want to tell Dan, we'll call him Mr. Gable, how you successfully manage patients with meningomyelocele? I want you to look at him while you think about this. Now, I've got a reasonably active imagination, and this is how I think it would go. I think Andrew would say, "Well, sir, I have them stick this tube in their urethra about 5 times a day and take this medicine, which keeps their pants pretty dry most of the time. And then I get an ultrasound and a urodynamic study once a year to see if there's been any damage." I'm not sure what he would say, but I think this is your response. "Yes, sir, Mr. Gable, sir. You could consider damage a loss." "Yes, sir, I'll say it with you, sir. Winners try to win. They don't try not to lose." "Yes, sir." It's another quote from Dan. I think most of us would agree with it. He's a big believer in starting with high standards and raising them. We make progress only when we push ourselves to the highest level. If we don't progress, we backslide into bad habits, laziness, and poor attitude. So I bring this up in light of our success story with meningomyelocele. We've clearly done a lot right and a lot good over the last 50, 60 years, as you've seen, but we've got a long way to go before I think you could consider us getting a gold medal. Yet I think that's what we've got to strive to do for these patients. Now, I promised an early exit opportunity for people. And what I've done here is taken what I thought was going to be the last slide. I'm going to put it up front because these are questions that I've got as I've gone through this that I'll put out there, again, for people to think about, challenge them, perhaps a resident's looking for a project, things like that. Is asymptomatic bacteria really harmless? In my mind, it doesn't quite make sense that the bladder is not going to respond in some fashion to chronic bacteria, even if it's asymptomatic. seems like it's likely to incite, again, my guess, some type of inflammatory response. You're probably going to lay down more collagen, more fibrosis, because the bladder is not supposed to let bacteria back into your bladder. A guess, but we ignore it by and large. Brought this up with the residents yesterday. A lot of our bladder neck procedures, we spare all that thick muscle and we try to wrap it around, and we're hoping magically somehow that compresses the urethra. But as I think about that, I'm not sure that's the right thing to do. Instead of just forming sort of a thin, supple tube that would be compressed with abdominal pressure, maybe wrapping it all in this thick stuff just leaves an open, fibrotic, thick channel. I don't know. Who should take care of patients like Julie as they progress into adulthood? I can tell you, my answer is it's not going to be the pediatric surgeons. They really do seem to be limited toward pediatrics and not dealing with adult cares. It's not going to be the orthopedists, who I don't think understand some of the other issues that they face. Again, I'm biased, obviously. It's not going to be the neurosurgeons. So clearly there's a role for urologists here in helping these patients. You know, we get these urodynamic studies, and I mentioned the high pressures. We don't like it above 40 centimeters of water. We know that's bad. But a lot of times I'll see patients, pressures are low enough, but they'll have quite a few unstable bladder contractions. They're not having symptoms at the time. I don't know how should I be very aggressive about treating this? Should we treat these patients like cystic fibrosis patients, where they show that if they see a drop in their pulmonary function test, if they're very aggressive with those patients, get them in, treat them, they live much longer. A lot of times we just ignore this type of thing. In fact, we don't have a great parameter of how many beats per minute or beats per mil should be concerning. But we see this all the time. There'll be some unstable contractions. I don't know how aggressive to be with that. What about doing a vesicoscopy instead of intermittent catheterization for a while? We can talk about nocturnal catheters, putting them in. They help a good bit. But on the other hand, we're putting in a chronic foreign body. And I think our adult colleagues will tell us that long-term indwelling catheters do seem to cause an increased risk of cancer development. So is this a good thing or a bad thing? I hold off on Botox until they fail, anticholinergics. Maybe we shouldn't do that. Maybe it should be a first line. I'm starting to do this more just in clinic. This may seem different to adult urologists who are used to doing cystoscopy in awake patients. In peds, we almost never do cystoscopy in awake patients. Yet this is a good population, I think, who's used to catheterization. So I've had a couple of kids that have tried it on, and they tolerate it well. Is there something we can inject besides Botox? So again, you're dealing with a bladder that often becomes hypertrophied, thick wall. We're paralyzing the muscle, perhaps, but what else could we inject that would get rid of some of that fibrosis or tap into the bladder's regenerative capabilities? I'll put a few slides up in a minute that stress this. I'm not sure we've got a good, if you will, hemoglobin A1C for the bladder. I'm not sure how, in these patients who often have neurogenic bowel, treating their constipation actually affects their bladder function. We know in the kids with voiding dysfunction that we see, if we treat constipation, bladder function gets better. But I don't think this has been studied very well. A lot of these patients get obese, fat, if you will. But I've got a few patients who are like Special Olympic athletes. They come in and they're thin and they're pretty good shape. And so those patients make me wonder, is this something that can be prevented, or are they just predestined to be obese? I don't know. I don't know how many get physical therapy and how that would help. We don't use peer mentors. We certainly know as they go into adolescence and actually adulthood, they stop cathing a lot. They stop being compliant with medicine. They stop being compliant with follow-up. Maybe if there are older peers that they respected a heck of a lot more than me or their parents, they might listen better. And speaking of the parents and families, this is a crippling illness. I remember Chuck Hotry, who was a pediatric urologist before me, had seen plenty of these patients in his time. he told me the first thing he did when his children were born, he flipped them over and looked at their back because he was just so concerned that they might have meningomyelocele. It's a devastating type thing if you think about it just for a minute. These patients will never have a normal life, and the families won't either. So think about those things. If you've got to leave early, you've heard sort of the big conclusion there. So let's get back to a few things we know, or at least we'll test on the examinations for resident students. It's not always as apparent that there may be some spinal issues. I think you're well aware of this. The last child that I saw that was picked up with a occult tethered cord was picked up by a medical student in my clinic. I actually did the back exam and saw sort of this fat pad, which was actually fairly subtle. But I went ahead and got the MRI, and sure enough, there was a tethered cord there. MRI in general is best. You can do an ultrasound in the first couple months of life. This just points out again for our residents and people taking exams, most of these lesions are down in the lumbar, lumbosacral area. A couple of things to point out here. Again, I'm supposed to stand here. The neurologic lesion, often lumbosacral. Note that the vertebral level doesn't always correlate with the neurologic level or correlate with the bladder function. And about 10% of children with meningomyelocele will actually have normal urodynamic studies. Elizabeth, I stole this slide from the course without asking permission, so just if you've got to close your eyes or something. It's a nice slide. It's just a reminder, again. I'll leave these slides here for the residents if they want to review. It just helps identify the pathways, and you can sort of predict if there's a lesion, neurologic lesion, what you may lose. You may lose bladder contractility, you may lose sphincter contractility. We often categorize these into upper and lower motor neurons type lesions. The upper motor neuron is going to be an overactive bladder and may have dyssynergia with the sphincter. And then, like any muscle, if you're making it work out, it's going to get bigger and thicker. The lower motor neuron lesion tends to have a relaxed sphincter muscle, and therefore there's not much resistance. The bladder tends to be more smooth and thin-walled. Just a reminder, a lot of these have an Arnold-Chiari malformation, where you'll get can get herniation, and this is what causes the hydrocephalus and where the VP shunt came in. One slide on fetal repair is all I'm going to put up here. And I think it's a fair summary slide. This was from the mom's trial. The idea was if we repair these children in utero, maybe we can make a difference. It seems like the only difference we really make is in decreasing the need for VP shunt. It didn't seem to help with their bladder or bowel function. That's my take. Andrew, Chris, John, you agree? Okay. So what do you do if you with a newborn? And there's a split. If you look at the bottom of the slide here, some recommend starting intermittent catheterization and anticholinergics right away. Others say, let's just observe the child. Okay. Why? Well, early catheterization, the proponents of that will say, 80 to 90% of these are going to end up needing catheterization. So you might as well start it. The parents get used to it, the child gets used to it, and you may prevent some of that damage to the bladder or to the kidneys. The observation group will say, we'll watch if there's any damage to the kidneys, we'll get urodynamics, kind of monitor the bladder, and if things start to change, then we'll intervene. But in the meantime, you don't burden the parents and the child with intermittent catheterization. You may have less chronic bacteria in there. I don't have an answer for you. There are a few indications where you should start it. If they're getting infections, if they're getting hydronephrosis, reflux, if you're seeing some changes, then clearly you're going to start treating them. Okay. Follow-up, most of us will get an ultrasound, as Andrew told Dan, at least yearly. Most of us will get urodynamic studies, and the frequency varies. So in the first year of life, I'll actually follow these kids about every 3 months with an ultrasound, and depending on how that bladder looks, will depend how often I get a urodynamic study. If things start to change, then you're going to start following them a little more closely. What do we look at on urodynamics? Well, usually it's fluorodynamics or video urodynamics. Fluoroscopy tells us a lot. Sometimes, as I mentioned to the residents yesterday, I start seeing changes on fluoroscopy above what I'm seeing on the tracings. And so oftentimes that'll affect my management more than just the tracings. The tracing will tell you the overactivity, compliance, all of that. At our institution, we use patch electrodes. I know needle electrodes are supposed to be well tolerated and more accurate, but we've just always used patch electrodes. What can you find initially? Well, you can look at the bladder and you can look at the sphincter. Interestingly, over half of them are going to have dyssynergia. And as I mentioned, Stu Bauer helped us learn, and others have confirmed, that if you've got that bladder working against the sphincter, you're at risk for a bladder that's going to deteriorate. And again, it's predictable. This is what you expect muscle to do. Okay. His conclusion is you need to intervene on these patients. Just a couple slides here on tethered cord for completeness sake. Tethered cord in general isn't as severe as you would expect as meningomyelocele. However, if you ignore it, these patients will deteriorate. If you treat it, they do better, okay? And their prognosis is much better than meningomyelocele. The thing you have to keep in mind with these patients, as well as those with meningomyelocele, as we discussed yesterday, is they can retether. So if the bladder's deteriorating, yeah, maybe it's just a local issue with the bladder muscle, but you got to keep in the back of your mind, it could be a retethering problem. Significant percent are going to have reflux. Be careful about operating on reflux in a valve bladder or a neurogenic bladder. There's a much higher failure rate and there's a much higher complication rate. And so the bottom line here is treat the bladder first. Treat these children with prophylaxis because they are at risk. That really is the take-home point from this slide. How often should a child catheterize? Parents will ask, you can start 2, 3, 4 times a day, but in reality what you're trying to do again is keep those pressures in the bladder less than 40, so you can adjust it based on that. If they're getting UTIs, and this is a tough concept for parents to get, the one thing that seems to have been shown, and there's not great data on it, is if you increase the frequency of catheterization, you tend to decrease the frequency of UTIs. And again, maybe that's mechanical emptying, or maybe Lapides was right that you're improving blood flow and lymphatic flow. I don't know. The other thing is that larger catheter has a lot less likelihood of causing a false passage. And so in adolescent boys, you should be using at least a 12 French catheter. It's amazing how many adults are still using a very small catheter. You don't have to always catheterize through the urethra. As pediatric urologists, we love this operation. But when I talk to my adult colleagues, they're not such big fans because they see the complications of this and they see the perforations or the failures and things like that. But from a pediatric urologic standpoint, it works. I reviewed a series when I was in Philadelphia at CHOP. We had what we consider a long follow-up. So 52 months is long in pediatric urology world. But in the adult world, what are we talking about here? 4 or 5 years? And you're talking about hopefully people with a 40, 50-year lifespan. So it's not terribly long. I know Andrew and Koresh and a couple others reviewed a series here and had similar rates of stomal revision. Their follow-up was a little bit shorter as well. Do you like how I made my name bigger than yours? Is sort of PRN antibiotics. I give my parents a prescription for antibiotics and just say have it on hand. They get very good at telling when a child has got a UTI, or at least if something's different, that gets cloudy, foul smelling. I have them treat and just say go ahead and start the antibiotics at home. If it's not clear in the next day or two, go ahead and take the child in and get a urine culture and put them on a different antibiotic. Not evidence-based medicine here, but I think as opposed to daily antibiotics, it's going to reduce resistance. I think it just makes it easier for the parents. Again, these are people who are afflicted with a huge burden throughout their life. If you can save them some trips to the doctor's office, it helps. Let's talk about overnight catheterization. This has come out, I guess, in the last 7, 8 years, something like that. It was interesting. For many years, we sort of ignored it. We said, okay, put the child to bed at night. You don't have to worry about things. But obviously, that bladder that you see doing this type of phasic contractions may not be sleeping at night. It may continue to do work at night. It may get chronically overdistended and have high pressure work going on. So it would make sense for those 8 to 10 hours during the day or night to help with drainage. And so we've started using this. Again, a couple unknowns. I don't know if we should be doing this more often before a child starts to develop problems. Should we use it as a prophylactic measure? And as I mentioned, chronic foreign bodies may have some issues. Koff is the one who popularized this, 19 children. Followed them for a couple of years. As you can see, quite a few of them had improvement in hydronephrosis, UTI, and continence. In a group with valves that he did this in, he actually saw improvement in their GFR in a lot of them, so their renal function improved. This is Kelly, one of my patients, and I think Kelly was probably about 10 years old, something like that. And this small number, her volume here at 125, and her pressure at that point is 70. Very non-compliant curve. This is what her bladder looked like. And I'll tell you, in the past, before overnight drainage, I would have looked at this and said, you're going to need an augment. This is an end-stage looking bladder. There's reflux. I got the urodynamics because she was starting to develop hydronephrosis on follow-up of her ultrasound. One thing I should consider and did consider is, could there be tethered cord? So again, keep that in mind. 2 months, just 2 months is all. Later, I had her back. She's now holding 360, something like that. Her pressure is now to 29. And this is what her bladder looks like. Yeah, it's not perfect, but after just 2 months of nocturnal drainage, this was impressive to me. And what it told me is that the bladder does have an amazing ability for rehabilitation and remodeling. And our challenge really is, how do we develop an environment to permit this to happen? Something to think about. Urethral dilation is not widely used. I remember doing it at CHOP for the first time, and they were influenced by people in Michigan who had said it not only lowers the leak point pressure, it also improves their compliance. And we would stretch these children up. 36 French is huge, and if you imagine doing that in a child, it stretches, it tears, it bleeds. And I remember talking to Dr. Snyder, who's a pediatric urologist there, and saying, so essentially we're just ripping apart the sphincter so they leak early. He didn't like that. He said, no, that's a pejorative term. He said, in fact, we are inhibiting the guarding reflex. I'm still not sure what he meant by that, but a few things that we don't know about this. How often can you do it? What's their future continence really going to be like? So it's not widely used. I don't know if you all use it here much at all or not. In some people, I guess it's an option. As you would expect, or hopefully I've alluded to, if you've got a tethered cord over here in the below, a lipomeningeal or sacral, you do have a higher chance of actually voiding and not using catheterization. So hopefully that would make sense. What are non-surgical options for continence? Intermittent catheterization, anticholinergics. Different ways you can do it. You can combine anticholinergics. You can put them intravesically. Some people have used things like pseudoephedrine to try to tighten up the bladder neck. My experience with that is very limited because, one, it's hard to get. 2, people were worried about strokes and things like that. And 3, I just don't think it worked very well. Botox has been used. I'll talk about Botox for a minute. You're all familiar with this now, I think. It's a neurotoxin. It works on inhibiting acetylcholine release. It also probably affects other receptors in the bladder. I think you could use it in combination with anticholinergics because it's a different mechanism, right? So one's preventing the release of acetylcholine, the other's blocking the receptor. So I think there probably is some synergistic effect. I keep my patients by and large on the anticholinergics when I use this. Dosage is there, a couple hundred international units. For whatever reason, the studies seem to suggest that higher doesn't seem to have an effect, so I don't quite understand why that is. But it works, and I use it a fair bit now. And there have been studies that show you can repeat the injections, and it seems to continue to work. So those are the non-surgical. Let's talk about some surgical options before you get into surgery. You got to do the preoperative evaluation. So you want to know what their pattern of incontinence is. If you're going to do surgery on it, are you treating an overactive bladder, or are you treating stress type incontinence, or both? If your child is not willing, or the parents more likely are not willing to perform intermittent catheterization, I would not do bladder neck reconstruction. Be very afraid of just doing an augment. I tell any of them that if we're tightening things up down below, there's a chance you're going to need to catheterize, even if they were avoiding. You want to know the status of the kidneys, the status of the bladder. Interestingly, some people are starting to say, well, even if the bladder looks bad, I think we can still put a sling around or tighten things up, and then we'll see how the bladder does. That makes me nervous. If I've got a bad bladder, high kidney, or damage to the kidneys, I'm much more likely to augment that bladder right up front. So what are the types of procedures? I'm not going into detail on these. For the resonance, if you want, in the slides at the end, and we're not going through it, I've got pictures of all these different procedures out of the textbooks. But in short, you've got the tube there. You can lengthen the tube, you can narrow the tube, you can compress the tube, or you can close it off. And that's what it really comes down to. All of these, with the exception of the last one, we're basically forming a controlled stricture. We don't have a good functional mechanism. We don't have truly an operation where we can put valves in to the urethra. What are the outcomes? None of them are perfect. They're listed here. As you can see, with the exception of injection, which is by far and away the worst as far as continence outcomes, you're running in a 50-75% range. Even when you combine some of these, maybe you'll get up to 75-80% if you combine bladder neck reconstruction and a very tight sling. So we don't have a perfect operation. There's a lot of room for improvement here. Injection, at least in my hands and most others, doesn't work so well. It's interesting, we're talking about continence, but as with most things, when you really boil down and ask, well, what do you mean by continence? We don't have a good understanding. So Lloyd did this nice literature review recently. Only 57% of the papers about continence really actually define what they meant by continence. It was somewhat shocking. Always dry, what you and I would consider continent, was only done in less than a fourth of those reports. Okay. Some said continence is dry if they're on intermittent catheterization. Every 2 hours, every 3 hours, or every 4 hours. Again, most of us aren't going to consider somebody continent if they have to catheterize every 2 hours, I think. But some papers put that out there. Some said they're dry if they don't use pads, so they just dribble a little bit in their underwear. Some said if they were using security pads only. Yeah, I don't know what security pads are either. Probably got a little star on it or a badge or something. Some said if they don't leak on urodynamic study, we don't care what they're telling us. You're dry. And 63% didn't say how a continence status was determined. This is what I like. Some authors, are the same authors on different papers, changed their definition of continence. So we really don't, at least in the literature, we don't know what continence is. But we know what continence is if you ask the patients. They want to be dry. Some second line, if you will, surgical options. You can try injecting after a failed bladder neck reconstruction or a sling. The results aren't great, as you can see there. You can close the bladder neck, and again, a study from here, they had a great success rate. It's at 96% success rate. Again, from a pediatric standpoint, long-term follow-up here, 69 months. I know when you talk about lifetime follow-up, that's not great. But even in that long, medium, short follow-up, whatever you want to consider, 3 of 28 ruptured, 1 of 28 had a stone, and they point out that only 82% were compliant with follow-up. These are high-risk patients, right? So I think all of them were augmented and had mitral phenol, so they need to follow up. Those are the data. I'll let them speak for themselves. Continent catheterizable reservoirs can be done. If that had to be done, frankly, I'd be asking my adult colleagues because they do this type of stuff more often. What do you do if your bladder is failing? About 15% of these bladders are going to get worse. I hope I've stressed this point. Rule out a neurologic cause first. And then you can start thinking about adding in other things. Botox we mentioned. I want to cover a couple more points here. Auto-augmentation and augmentation cystoplasty. For the residents, that's Sally Campbell, is just a list. We won't go through all the drugs. This should have worked, the auto-augmentation, but it didn't. It made sense, where if you removed a lot of that thick muscle, you could get the bladder to grow. This doesn't project real well. This is not an auto-augmentation. This is a big periureteral diverticulum in this child, and you can see it's about as big as the bladder. So what it tells me again is the bladder's got this innate ability to grow or regenerate. How can we tap into that? It should work. When you histologically look at this, all it is urothelium, lamina propria. So you don't need the muscle around to grow the bladder. How can we do this? I don't know, but the bladder's got the ability. And so maybe some of you smart guys, some of you people who are in the lab can figure out how we kill off muscle cells without causing inflammation that will contract things down and just let the urothelium and lamina propria develop. It was a good idea in theory, as you can see, and again, another study from this institution showed that it just doesn't work very well. There's another study out recently, Hansen, in the Journal of Urology this year, said, well, if you pick kids who have an estimated bladder capacity over half of what it should be, it works in those kids. So their thought was maybe if you get them before they're sort of totally end stage, it would work. Doing a bowel augmentation for the bladder, we mentioned this yesterday, it doesn't even sound like a good idea on paper. It works, but it's got complications. And I now consider when I'm doing it, I used to do it a lot more frequently, I now consider it a failure, almost somehow a failure of medical management or some other type of management, letting these bladders get to this point. How likely are they to have an augmentation? Again, varies with the level, as you would expect. Why don't I like it? There's a lot of complications here. Electrolyte complications, stone formation, perforation. Again, most of these are with relatively short follow-up. Okay. Metcalf reviewed a big series, I think, from Indiana, and a third of them needed additional operation just within 13 years, which again seems like long-term to us, but with our adult urology colleagues here, that's not long-term. And this is where the adults have to pay attention, because a lot of these things occur after these children or young people have moved on. For the residents, we're not going to go through the advantages and disadvantages, but they're there and they're well known. What about regenerative medicine? Tony Atala caused a bit of a stir in the pediatric urology world a few years back when he presented, actually published these results, and they got published, I think, before they were ever really presented at any of our meetings. And suddenly parents were calling us and saying, hey, we want one of these new regenerative bladders. And when you look at the study, the results were not great. And basically he's growing sort of bladder tissue, several layers, in a petri dish, if you will, bathed in serum. And then the idea is you take that out, you open up the bladder, you put it on there. It's now bathed in urine on one side, and you're hoping that it's just going to sort of grow and get blood flow into it. It didn't work so well. Others have tried to reproduce it. I don't think this is going to be the answer. I really think the answer is going to be tapping into the bladder's ability, that innate ability to regenerate. And I think that's the better way to go. For completeness sake, another professor, I guess, Professor Zhao from China, created another stir that got parents calling into us. They wanted the Zhao procedure. And what he demonstrated was that you could do some nerve rerouting. And you would harvest a nerve and bypass, essentially, that area that wasn't working. And then the children could scratch their thigh, and there'd be a reflex arc that would cause the bladder to contract, and they would pee. I could understand that. That makes sense that you could do something like that. What I couldn't understand was his claim that it was a coordinated contraction, and that the sphincter would relax as well. And so these results were terrific, and parents all wanted it. It was, my God, I don't have to have my child on catheterization. They can just rub their thigh, they'll pee, everything's going to be okay. Last I heard, maybe you all know, he was in prison, and so something bad happened. And others have tried now in the States, tried to reproduce this, and this is the results. It didn't seem to work as well as was hoped. Doesn't mean it's not worth continuing investigating in this area, but what I told my patients when they were asking is, let's hold off. Let's wait and see if it's as good, because we can do it down the road. What's their quality of life? Another study. You guys should really be giving this talk instead of me. But there's a lack of evidence showing that if we improve continence, their quality of life gets better. Why would that be? Well, I think some of the conclusions were our instruments weren't so great at really detecting this. A couple of other studies came out and said, well, you need better instruments. You actually need personal interviews so you can really get at this. So part of the problem, I think, with quality of life and asking people before and after, especially children, is you start to get these fuzzy memories. I don't know if you all remember those fuzzy memories by Jack Handy. Yeah, there's a couple that seem appropriate. This one says, maybe it's my imagination, but food seemed to taste better when I was a kid. Also, food would sing and dance and play musical instruments, but that could also have been my imagination. I like that one, and here's a urologic one, I thought. I'll let you read it to yourself. It's appropriate pediatric urologic fuzzy memory, so that may be affecting some of our quality of life estimates as well. A few final slides aimed for our adult colleagues here. I think I've got 4 slides left, so bear with me. At puberty, there's increased concern over body image. I mentioned this already, decreased compliance. 2/3 of adults don't follow up regularly. Over half have stopped their catheterization. Over half use a catheter that's too small. Our recommendation for follow-up, the yearly ultrasound creatinine, it's not evidence-based. Should we be doing more often, less often? Oh, we don't know. Interestingly, 60% of our adults, despite all our efforts in kids, over half of adults remain incontinent. A lot of barriers, as you all know, to moving them from a children's hospital to adults and getting people to follow up and accept care and who should be taking care of them. And let's remember, it's not just urologic issues that these people face. If you look at the cohort that was in my sort of age range, I was born in '65, 33% dead before age 5, but 26% more dead within the next 35 years. And a lot of what you see is either neurologic, pulmonary embolism, pulmonary type issues. Sexuality, this is frightening to me. I've got teenagers now, and I should know this, but 28 to 40% of our MMC teenagers have had sexual encounters. It's not so shocking to the younger generation here. Women more likely to have sex than men. Only half of them satisfied with their sexual lives. That doesn't seem so low to me. Almost all of them desire to marry and have children. Sildenafil does help. and depending on the lesion, they are more or less likely to have function. What about kidney failure? Actual frank stage 5 chronic kidney disease isn't that common, but but if you follow them long enough, maybe it will be. And finally, cancer. These patients seem to have an increased risk of developing bladder cancer, and it's not just a transitional cell. It can be adeno, it can be squamous cell. And in a review that we had, we looked at 8 of our patients. They presented at a young age, a very advanced stage. Survival was terrible, 6-month median survival. Interestingly, only 1 of 8 had an augment. So again, these patients are at increased risk for bad cancers, and it's not just the augment that does it. There's a baseline increase. It's unclear, though, if screening would have helped. Most of our patients presented with some hematuria in retrospect. Some of them had been scoped before within a year, so it's unclear how we should treat those. So with that, I'll take any questions. You guys are reasonably close. Thank you.